Okay, so in the previous slides, we have seen about the drugs for bronchial asthma, then how the mechanism has been taken place for the same, what are the trigger factors, and even we have detailed looked out approaches to the treatment. So let's start with the classification of drugs in the bronchial asthma. The classification of drugs applied in this way. First, bronchodilators. In these bronchodilators, three parts are there. That is a beta 2 sympathomimetic, methylxanthines, and anticholinergic. So in bronchodilators, this three categories like a beta 2 sympathomimetics. In this, we will study about the salbutamol, terbutaline, bambuterol, salmeterol, formoterol, and ephedrine. In the methylxanthine, we will look out theophylline, which is anhydrous in the form, then aminophylline, choline, theophyllinate, hydroxyethyl theophylline, then theophylline ethanolate of piperazine derivative, and doxophylline. And in the anticholinergics, we'll see the ipratropium, then ipratropium bromide, and tiotropium bromide. So these are the three classes, subclasses under the heading bronchodilators. Now, second is after bronchodilators, leukotriene antagonist. In leukotriene antagonist, the montelukast and zafirlukast drugs we will see. Then third category after bronchodilators, leukotriene antagonist. Third is a mast cell stabilizers. In this, we will see the sodium chromoglycate and ketotifen. And the fourth category after bronchodilator, leukotriene antagonist, mast cell stabilizers. The fourth category is corticosteroids. So again, corticosteroids in the two parts, that is a systemic and inhalational dosage form. So in the systemic, we will see the hydrocortisone, prednisolone, and others. And inhalation may beclomethasone, dipropionate, then budesonide, then fluticasone propionate, and flunisolide, and then cislesonide also we will see. And the last is a anti-IgE antibody. Here we will study omalizumab. So let's start with the first, that is a sympathomimetic. Simply we are calling it like a bronchodilators class, first class. So sympathomimetics, generally adrenergic drugs cause bronchodilation through beta 2 receptor stimulation and increased CAMP formation in bronchial muscle cells. Relaxation. In addition, it increases the CAMP in the mast cells and other inflammatory cells, decreases mediator release. Since beta 2 receptors on inflammatory cells are more prone to desensitization, the contribution of this action to the beneficial effect of beta 2 agonist in asthma is uncertain. So here adrenergic drugs are the mainstay of treatment of reversible airway obstruction, but should be cautiously used in hypertensives, like ischemic heart disease patients, and in those receiving digitalis. So they are the fastest acting bronchodilators when inhaled. So through adrenaline, though adrenaline and isoprenaline are effective bronchodilators, it is the selective beta 2 agonist that are now used in asthma to minimize the cardiac side effect. So this is the mechanism of action and the precautions while using sympathomimetics. So the first drug is salbutamol, which is also known as albuterol. It is a highly selective beta 2 agonist. Then cardiac side effects are less prominent for this drug. Selectively, it further increased by inhaling the drug. Selectivity of this drug. Inhalation is more important. inhaler dosage form is more important for this. Then inhaled salbutamol produces bronchodilation within 5 minutes, and the action lasts for 2 to 4 hours. It is therefore used to abort and terminate the attacks of asthma, but it is not suitable for round the clock prophylaxis. Then muscle tremors are the dose related side effect for this salbutamol. Then palpitation, then restlessness, nervousness, throat irritation, and ankle edema can also occur. So basically we have seen it is highly selective beta 2 agonist. It can be administered in two routes, inhale route or oral route. And this inhaled salbutamol produces bronchodilation in a 5 minutes, and it lasts for 2 to 4 hours, and it's used to prevent terminate attacks of asthma. And orally viability is 50% due to its digestion in the gut wall, and its action lasts for 4 to 6 hours. Then side effects we have seen the palpitation, restlessness, then throat irritation, ankle edema. So these are the side effect. And one more important point I want to mention here, basically that salbutamol undergoes a pre-systemic metabolism in the gut wall, what we have discussed in the previous slide. This oral bioavailability is only 40%, 50%. So inhaler route is always preferable for salbutamol. But oral salbutamol act as a 4 to 6 hours dosage form, and which is considering longer acting and even safer than isoprenaline, but similar in efficacy. But because of more frequent side effects, oral beta 2 agonist therapy is reserved for patients who cannot correctly use inhalers or as an alternative or adjunct drugs in the severe asthma. Those who cannot inhale in a proper way, for them the oral therapy is being used. So the dosage for this is 2 to 4 mg oral, 0.25 to 0.5 mg intramuscular and subcutaneous then 100 to 200 microgram by inhalation. So this is about the salbutamol. Now let's see the next sympathomimetic drug, that is terbutaline. It is similar to the salbutamol in properties and use. And dose for this is 5 mg, 0.25 mg subcutaneous, 250 microgram by inhalation. Then effect of regular use of salbutamol and terbutaline is regular use of these two drugs may increase bronchial hyperresponsiveness. Basically inhaled salbutamol and terbutaline are currently the most popular drugs for quick reversal or bronchospasm, but should not be used on any regular schedule. This is the important point. Then regular use does not reduce bronchial hyperreactivity, may even worsen it sometimes. This is one of the drawbacks. This may be responsible for the diminished responsiveness which seen after long-term use of these drugs. So regular use also down regulates the bronchial beta 2 receptors. It is generally advised that patients requiring regular medication should be treated with inhaled steroids, and use of beta 2 agonist inhaler should be restricted to symptomatic relief of wheezing. So this is about the terbutaline. Now let's have a quick remembrance of other drugs in the sympathomimetic, that is bambuterol, salmeterol, then formoterol and ephedrine. The source of this bambuterol is biscarbamate ester. The mechanism of action is this drug is slowly hydrolyzed in the plasma and lungs by pseudocholinesterase. Now, this is bambuterol is the biscarbamate ester product, and it is slowly hydrolyzed in the plasma and lungs by pseudocholinesterase to release the active drug over 24 hours. This reversible inhibition of pseudocholinesterase occurs in a dose dependent manner. So, it is indicated in a chronic bronchial asthma. This is specially for chronic bronchial asthma in a single evening dose of 10 to 20 mg. As far as side effects are concerned, there are very mild and even no side effects for this drug. Then salmeterol, it is a first long-acting selective beta-2 agonist with a slow onset of action, used by inhalation on a twice daily schedule for maintenance therapy and for nocturnal asthma, but not for acute symptoms. But not for acute symptoms. This is the important. It is also more beta-2 selective than salbutamol and more lipophilic, which is probably accounts for its longer action. So, concern of asthma worsening due to regular use of inhaled beta 2 agonist, which applies to salmeterol also. So, however, clinical studies have shown sustained improvement in the asthma symptoms and lung function. Concurrent use of inhaled this salmeterol with inhaled glucocorticoid produces effects equivalent to double dose of the corticoid alone. So it is advocated that long acting beta 2 agonist should be used only in combination with an inhaled steroid, and combined formulations are also available in the market. So this is in general about the salmeterol. Then formoterol, this another long acting selective beta 2 agonist which acts for 12 hours when inhaled. In comparison to salmeterol, this formoterol has a faster onset of action. It is used on a regular morning evening schedule for a round the clock bronchodilation, and the dose for this is 12 to 24 microgram by inhalation twice daily. Then the ephedrine, uh, this is the another sympathomimetic drug. It has a alpha plus beta 1 plus beta 2 actions, and it causes mild slowly developing bronchodilation, which is lasting for 3 to 5 hours. It is a constituent of older combination formulations and is used for mild to moderate chronic asthma. This is for mild to moderate chronic asthma. And because of low efficacy and frequent side effects, it is not preferred nowadays. So, this is all about the bronchodilators, first class sympathomimetic, that is a beta 2 agonist. Now let's discuss some MCQs on this respiratory drugs. This is which of the following is not a quick relief medication for asthma. So this one by one we will study, but you people just have a collection of MCQs with us, with you people, so that after finishing this chapter we will have a bunch of MCQs. We can practice more on that, and even after at last we'll take a separate lecture on this MCQs. So these are some few more MCQs. Like the following is true about theophylline, except then which of the following is a short acting leukotriene synthesis, that is a 5 lipooxygenase inhibitor. Then which of the following can be administered orally and by inhalation? This already we have seen. This is the terbutaline. We are taking it as a orally as well as by inhalation. Then which of the following combination is false? So this is all about sympathomimetics.